want to say welcome to this session on utilizing radiofrequency ablation to treat metastatic bone disease, a case-based presentation. This is sponsored by Medtronic. The faculty, myself, MK Jesse, an associate professor at the University of Colorado School of Medicine in Denver, Jason Levy, an interventional radiologist, Northside Hospital in Atlanta, Georgia, and Jay Morris, he's one of my partners here at the Mayo Clinic in Rochester, Minnesota. These are our disclosures. Want to emphasize that this has been provided by the North American Center for Continuing Medical Education, an HMP company, and as I said, provided by an educational grant from Medtronic. The learning objectives for this next hour is to recognize the current treatment options for metastatic bone disease and when to use each, understand the value and applications of radiofrequency ablation, both palliative and curative, and identify the clinical evidence to support this use, and also identify the appropriate time to use radiofrequency ablation in conjunction with other oncology treatments, such as radiation. So first, just a brief overview of the ablation methods that are used in the treatment of patients that have metastatic disease. And I think it's first important to put it into context relative to how patients do with radiation therapy, which is still considered the gold and standard therapy for treatment of these patients. For these patients, there have been multiple trials that have demonstrated that it takes about a month to achieve pain response when treated with radiation therapy. Many do, however, achieve pain relief over a period of time. But unfortunately, superimposed on this is also the fact that about 20% of the patients that initially responded will have recurrent pain within 1 to 2 months. So it does work for some, but also the duration of response when treated with radiation therapy is relatively short. So if you're confronted with a patient that has a metastatic disease, for example, this patient with a tumor contained in the scapula, you have a couple options, and we'll hear about that today. Heat ablation, RFA, microwave, MR-guided focused ultrasound, and also cryoablation to treat these types of tumors. So it's important to understand what your goal of therapy is. If it's palliation, incomplete treatment may be okay, and we'll learn about the boundary zones for that. Local control, it's really important to have a margin and have an understanding of how aggressive you need to be. The size of the lesion, if it's really small, you can treat it with a single applicator. But if they're larger, you really need to use overlapping ablations or do single stage treatment with multiple devices. And then you're concerned with boundary issues such as the adjacent anatomy. In particular, the adjacent motor nerves, it's important to know where they are. Cost is also an issue, but I think the outcome of the procedure is dominant here. And so you need to make a very careful selection in terms of how you approach this. Doing multiple overlapping ablations is not necessarily a good approach when you're trying to get local control. So if you weigh the different technologies in general, I'd put them into 2 buckets, at least for now: cryoablation and radiofrequency ablation. IRE is a technology that's coming. We're going to learn more about that over the next few years. For cryo in general, large-sized tumors, if it's sclerotic, it doesn't matter with cryoablation. If you need to worry about adjacent normal tissues such as small bowel or colon, skin, or nerves, cryo, you can still see these. It's a visible location. It's difficult to do cryo in the middle of bone without MR, so it doesn't provide much of an advantage. If you have a need for local control, it's easier to use multiple applicators with cryoablation. Radiofrequency ablation is really excellent for small size lesions such as osteoid osteoma. We'll hear many cases where it's helpful with near adjacent neural tissue such as the spinal cord or in the posterior elements of the spine. Or ice isn't visible, as I said, in the spine, RFA works extremely well. If you're also going to follow treatment with cement, RF works well because you don't have to wait for the ice ball, for example, to thaw if you use cryoablation. So first efforts into this area to find out how well ablation worked in treatment of patients that have metastatic disease was using radiofrequency ablation back in 2001. This shows how the field is really advanced, and we're going to learn that now treatment, where we excluded trying to treat tumors that were near the cord or the brain or adjacent to other tissues, specifically to avoid complications. And we're learning a lot, and new devices really broaden the scope of patients that can be treated. These are the types of devices that were present or available back then. These were monopolar RF devices, and it was a whole different approach in terms of trying to treat these patients to get palliation. Multiple trials have been conducted, and we're going to hear from Dr. Levy about how well patients do in general, but many of the response curves look like this. And this was one trial that was published in Cancer, and using the brief pain inventory as a measure of outcomes, specifically mean worst pain at presentation. Many patients have significant pain when treated, and those that have failed radiation therapy. You can see that most patients do extraordinarily well over time, and here you can see patients were followed for 24 weeks and had an excellent outcome in the response to their pain. And I would say in general, it's very similar with different ablation devices as long as the treatment is done appropriately. So where does cryoablation work? Here's a patient that had previous treatment with radiation therapy but had an enlarging lesion in the iliac bone, which you can see here. Cryoablation was used to treat this. Here you can see that it was approached from a posterior extent. And iced, you can see exactly where it is in the soft tissues. And you have to kind of, by measurement, determine how deep you are into the bone, since you can't see it with CT. That patient did well following treatment. I mentioned monopolar RF was where this all started. Now bipolar RF really dominates treatment for patients. There's a couple different approaches. One is use a multi-probe system where you conduct between electrodes, or you use a single probe system, which is more common, where you have an insulator separating the active tips or the components, the electrical conduction in these systems, and it basically circulates around the electrode. So this is the most common approach with bipolar RF. One of these devices is made by Medtronic and was specifically designed for vertebral body ablation. We're going to see several examples of how this system works well in the treatment of these types of patients. Specifically, posterior ablation edge as the posterior aspect of the vertebral body is prescribed by how these devices are placed. And again, we'll learn more about that in the next minutes. So an example of how this is used, you can see a lesion in the L5 vertebral body in a patient who had metastatic prostate cancer. This procedure was done by my colleague Jay Morris. You can see that this is bracketed by 4 bipolar ablation devices, so you can completely cover this sclerotic lesion. And here you can see follow-up with a choline PET, where there's no residual activity in that L5 vertebral body. So in summary, goals of therapy, we're going to learn about palliation versus local control. Ablation is effective for both palliation and local control, and many ablation systems can be utilized in the treatment of these patients. Device selection really comes down to size, location, whether you need to see what you're doing in terms of the ice ball margin, for example, and whether you're trying to achieve local control. And also perineural treatments, bipolar RFA systems are really well designed in the treatment of patients with metastatic disease involving the spine, and we'll learn more about that as we go through this hour. So in the next 45 minutes or so, we're going to learn more about how these different approaches can be used to treat patients with metastatic disease. And our first speaker will be Dr. Jay Morris.
All right, thanks for having us here to discuss the role of radiofrequency ablation in patients' treatment plans. My name is Jonathan Morris. I'm from the Mayo Clinic in Rochester, Minnesota, and I'll be the first speaker in a series of speakers that will each discuss the role of radiofrequency ablation in tumor patients. I don't think it's a secret that there's a greater number of patients diagnosed with cancer year after year, and if you look at 2010 to 2030 projected numbers, there's a 45% increase over a 20-year span of patients who get diagnosed. And the incidence or number of patients living with cancer continues to also increase exponentially, with about 8 million males and 8.8 million females living with cancer in the United States. It's estimated by the SEER data that the number of cancer survivors in the United States will increase by more than 5 million by 2030. You know, that's 16.9 million survivors in 2019, going up to 22.1 million survivors in 2030. And it's due to a few things. One, there's a growth in the aging population. Two, there's advancements in early detection, and then really there's been a lot of advancements in the treatment of all these patients with cancer. Bone metastasis is the most common metastasis. It can occur in autopsy series up to 70% of people with cancer. And spine, which is a place I work the most in as a neuroradiologist, is the most common bone to have metastatic disease. And when you have metastatic disease, you have several treatment modalities. Most of our patients are on some sort of chemotherapy, immunotherapy, hormonal therapy, or something along those lines. Our patients often have gotten radiation either in concert with what we're doing or previously gotten radiation in a particular area. Our patients have sometimes undergone surgery in other areas or in combined with what we're going to do. And then there's what we do, which is thermal ablation, which today we're going to be talking about radiofrequency ablation, and I'll show cases mostly in the spine and leave some of the other osseous sites to the other speakers. And in reality, thermal ablation is combined with many of these other treatment modalities in the total care of the cancer patients. So if you look at the clinical practice guidelines in oncology from the NCCN, if you have a patient that's diagnosed and suspected of having spine mets, well, if they're asymptomatic or it's an incidental finding, they're going to get imaging, workup, biopsy if necessary, and then choose one of those treatment options that we talked about. If they're symptomatic, however, and it's severe, new, or progressive pain, they're going to get imaging again, and most of the time it's a spinal MRI unless they can't have an MRI, of which times we can sometimes use CT myelograms. If there's no tumor, well, you can evaluate for other causes of pain. However, if there's spinal cord compression, most of our patients get high-dose steroids followed by surgery, radiotherapy, or radiotherapy alone, along with chemotherapy. And in some cases, like we'll show, we do ablation in those patients. If there's no spinal cord compression, you want to know whether they have a fracture or spinal instability or a potential fracture, and we'll talk about that. And they can go on to either get surgically stabilized or have a vertebral augmentation plus minus ablation, and then plus minus followed by radiation therapy. Now, if there's no fracture, then they usually get radiotherapy or chemotherapy, and in some cases surgery, and we'll talk about some of those cases. Now, it's really important to consider yourself as a multidisciplinary team member. There's all sorts of people in the role of a cancer patient, and you're just one arrow in a large quiver. You're one option, and it's important that we add this option because it gives a lot of patients more options than they previously had. And the goal really is either to relieve pain and be palliative, prevent delayed skeletal events such as fracture or catastrophic cord compression, to treat the tumor, either primarily treating the tumor or combined treatment tumor, and restore their quality of life. And you have to think of several things when you're doing any of those. What's their life expectancy? What's their predicted response to other therapies? What's their past response to therapies? What's their predicted outcomes? What's their overall disease characteristics? And you have to consider what the patient's preferences are, and we'll talk a little bit about that. Now, in 2015, a whole group of us got together and published this Metastatic Spine Disease Multidisciplinary Working Group. And this is a busy algorithm, but I wanted to show it because it shows in many places. And although we're talking about the spine, I think this applies to almost every osseous location where thermal ablation could be indicated. In asymptomatic metastasis, you can see if there's less than 3 or greater than 3 in a long life expectancy, it's surely indicated. And I'll give a caveat because in A, we didn't put ablation at first, but we see many patients that are going to live less than 6 months who are in pain, and we definitely do those patients for palliative reasons. In patients who have uncomplicated spinal metastasis, you can see ablation is in all 3 rows, whether their life expectancy is low or high. Patients who have stable pathologic compression fractures, you'll see that ablation plus cement augmentation has been added to the algorithm. And I would say that even in some unstable pathologic compression fractures, some of these patients are not all surgical candidates. A lot of patients aren't surgical candidates for corpectomy or multi-level separation surgery. So in those cases, we do ablation, and you'll notice it says vertebral augmentation here. Ablation makes vertebral augmentation safer. We'll talk about 2 technologies, and the first one we'll look at is the Merit Star Tumor Ablation System. It's a curved RF ablation system, and it has a curved osteotome, which is in the lower portion of the picture, which helps carve a hole for the ablation device. Now, it has thermocouples, both distal and a proximal thermocouple, which we'll talk about a little bit, because when you put this device in, the central part is radiolucent. And as you turn it on, the radiofrequency bipolar energy will grow to the distal thermocouple, which is a centimeter away in a 10 by 15 probe. And you can extrapolate that the ablation zone is a centimeter the other way out to the tip. Now, this is in a 10-15 probe. There's also a smaller probe. And as it grows, you can extrapolate out further that now you can get a 3 by 2 ablation zone. And you can see the temperatures on the distal and proximal thermocouple in the lower hand picture. Now, I'm going to talk a little bit about oligometastatic prostate cancer because it comes up a lot. We treat them at the time of diagnosis, develop METs while on other treatments, or they develop METs after treatment during a metastatic-free interval. For example, like maybe they were on Lupron for 10 years and now they're off and they haven't had any METs. It's the number one MET we treat, secondary to the success of nuclear pharmaceuticals such as PMSA and at our institution C11 choline that can find small METs. And if we can treat these with ablation, it delays the time to androgen deprivation treatment, as well as improves androgen deprivation therapy-free survival. And it's really due to these nuclear pharmaceuticals like choline and PMSA that have helped us find METs earlier. So here's a case with an older gentleman who has biochemically recurrent prostate cancer in the middle of the vertebral body. Here we're taking a paravertebral approach. You can place the curved osteotome through, carve a hole, and then this is a 510 probe, which will give you a 2 by 1.5 centimeter burn. And you can see we can curve it along the back of the vertebral body, articulate it so we can get closer to the cord. Now, it's important to remember that when patients get radiated, this is not this patient, but a patient, that they give a background dose. And I will tell you, if you're trying to do local control with radiofrequency ablation, you want to do overlapping burns, because when we started doing this, 7 years ago or so, we started having marginal recurrences. And we had to learn that you had to over-treat it, much like they give background dose, because what we see on PET is not all the tumor. So here we're doing an overlapping burn, and you can see even at a year follow-up, there's durable local control. Now, if there's not a hole in the bone and it's prostate cancer and it hasn't been radiated, I do not put cement in those patients, and we've had very few, less than 5%, go on to have any fractures. And the reason not to is if you have to go back here, you can't do radiofrequency ablation in cement. It's a rock, there's no water, you blew that option. So we don't always put cement in those. Now, here's another patient who's got a catecholamine secreting metastatic paraganglioma. Now, we see a lot of these SCHB mutated patients, and they've lived a long time with metastatic disease, and from time to time they come back with METs because they're going to MET their whole life if they have that mutation. So here's a case up at C2. C2 is off-label for radiofrequency ablation of any device. And here you can see the lesion. There's the vertebral arteries, the carotid arteries, but we've got a pretty nice look at it through the pedicle. And we have to think, well, there's an anterior spinal artery in there feeding the cord. So here we put our introducer needle in, our curved osteotome, and our curved radiofrequency probe. It fits perfectly in this location, and this patient is out now 5 years, no recurrence in this location. If they failed all of the treatment, so here's someone who's been living with oligometastatic prostate cancer for 10, 15 years by the time we saw him. He had biochemical recurrence. He had a history of radiation. And after radiation, he got a radiation-induced plexopathy. So I can tell you his excitement about getting more radiation is really low. And it's in a tricky spot in the back of the T1 vertebral body right against the cord. There's very few technologies that can treat this lesion focally in somebody who's burned their radiation bridge. Now, if you're treating T1, I can tell you that tilting a scanner 19 degrees forward or working in a biplane fluoroheme with 20 degrees towards the head and the shoulders in the way on the lateral is not pleasant. So we've taken approaches to do inferior pedicular approaches, which work quite well in the upper thoracic spine. We're actually writing it up right now, where we go through the inferior pedicle under the exiting nerve root into the superior vertebral body and avoid all that tilting. And we can put our curved osteotome in, our curved ablation device. Here you can see it overlaid, and then treat this area along the back of a high thoracic vertebral body, and here it is in coronal, and get durable local control. Now, the next technology I'll talk about is the Medtronic OsteoCool device. And this is cooled radiofrequency. One of the problems with Merit is that it gets char on those little coils, and you sometimes have to take it out, put it back in, clean it off, put it back in, clean it off, put it back in. It also, the power only goes up to 10. So this device, the power goes up to 20, and it's algorithmically driven. So here we get access to a vertebral body. You park the needles at the vertebral body pedicle and body junction. You place a small hand drill through that needle, and the hand drill is color-coded to tell you the size of the ablation. So if you go down to the blue, you can see the size of the ablation gets bigger. Now, that's not the tip of the needle. That's the size of the overall ablation. And this is what it looks like in a patient we're treating the upper thoracic spine. You can see we've got the hand drill inside of the needle down to the 15-millimeter probe. Now, when you plug in the probe, like probe B here, you can see it's at 15 minutes. That's one thing that tells you it's a 20-millimeter probe, because the 20 millimeter is 15 minutes, the 15 is 11.5, the 10 is 7.5, and the 7-millimeter probe is 6.5. So it's some visual evidence that shows you which probe is in there. The other thing you see here is it gives a certain power to get a certain temperature at a certain ramp rate. So it automatically adjusts the power to automatically increase the temperature. You don't have to play with the power at all, and it can get up to 200 above baseline resistance, and it keeps it at 70 for a length of time. When you're pulling back, I would suggest you retract or say you put it in retract mode and burn the track on the way out. We have had patients who have had recurrence in the pedicle, because remember, if you're primary treater, it's not like a biopsy where they're going to go get radiation. And you can spread them out a little bit further to get a dog bone appearance, or a little bit closer to get a straight line across that back wall, which is one of the benefits of putting two probes in. I'm going to show just a few examples, because I know there's a lot more examples coming. But here's a patient diagnosed with lung cancer, PD-L1 status 0%, had an upper lobectomy, had mid-thoracic back pain, which led to the diagnosis of a large lytic metastasis. Now, this patient went on to have radiation. The patient is seen here, goes on to have radiation, had good pain relief after radiation, and then had immediate pain recurrence in 2 months later. And you can see exactly what you would expect to happen, that the vertebral body has fractured upon itself. So any bone that has greater than 40% lytic destruction in the spine has a high propensity to fracture. So we try and treat those up front before they collapse, because now there's some retropulsion. It makes it a little bit harder. The tumor is still there, obviously, because they just had radiation a month ago, and it doesn't work like immediately. It takes a little bit of time for all the cells to die to get PET negative. So here we can map it out. If it can fit 2.9 millimeters, it can fit a 20-millimeter probe. It's 3.8 side to side. Now, you're only going to get 2.1 tall, so this is a good vertebral body for that. And here we place bone access needles, the hand drill. We place the probes through the hand drill. I try and get the probes just on either side of the spinous process. We ablate the lesion using the algorithm and fill that hole with cement and tie it into the pedicles. If you're treating lytic metastasis, it's nice to tie it into some normal bone, because we know cement does not adhere to the bone in lytic cavities. You can see no further retropulsion. For patients with metastatic breast cancer who have had radiation of the chest wall and had a bad response to radiation, when they come with the metastasis, they ask, is there something I could have because I had this bad reaction and a plexopathy related to my radiation dose? And here's a patient that we were asked to do ablation. This is doing it under CT, but it's the same thing. Hand drill, placing the probe through the pilot hole, 8 millimeters apart means you'll get 4 millimeters wide, 4 centimeters wide, and then filling it with bone cement, giving it structural support. And you can see there the follow-up. Now, this is the one slide I wanted to show, because this is really what we try and do instead of that first case. Patient has a long history of cancer, renal cell cancer, metastasis, treated with SBRT, had a failure to radiation, treated with corpectomy, and now shows up with a new met. So this tumor has always told you it's radiation resistant. And even though it's renal cell, we have 85% local control rates of renal cell in our radiation group. So it's radio resistant, but 85% is pretty good. But this has told you it's going to fail because they already had a corpectomy. So we're going to not just radiate this, we're going to radiate it and do ablation. And contrary to that other case, what we've tried to do really hard over the last 6 or 7 years is tell the radiation oncologist, who we work with closely, to let us get these patients earlier. And contrary to when we just used to put cement in and potentially push tumor back into the canal, here we can ablate the tumor, blow balloons up inside of that lytic cavity, put cement in, and then tie that into the normal bone. And here we get durable local control with radiation as an asset, and we don't wait for it to fall down. We've really gone to treating these as fast as we can from radiation so we can prevent the collapse, prevent kyphosis, prevent retropulsion. So in conclusion, for my part, I'd say that bone metastases are really a common cause of oncologic morbidity. The current treatment options, while great, do have limitations, particularly as the patients go on to live 10, 15, 20 years into their disease. There's a growing body of literature that Jason Levy is going to discuss about what we talked about, and you're part of a multidisciplinary treatment group. And radiofrequency ablation, the setting of vertebroplasty, is just one more tool that you have to improve the lives of those suffering with cancer. So I'll stop there. And we'll talk a little bit later and let some of the other speakers talk about their experience. So thank you for allowing me to come here and speak.
Hey, I'm MK Jesse. I'm from the University of Colorado Hospital. And here in the next 10, 15 minutes, I'm going to be talking about palliative versus curative applications of radiofrequency ablation and largely talk about this in a case-based presentation style. So just as a quick introduction, radiofrequency ablation has not been around that long. It was introduced in the early 1990s, and it's very well established in the treatment of osteoid osteomas, but in the last 10 or 20 years, there's been increasing utilization of thermal ablation in benign and metastatic disease. And as we have started to explore the utility of this device in metastatic disease, it really brings up the question of, are we really trying to get local control and delay in progression, or are we trying to get a palliative effect? And generally speaking, that local control we're going to use in patients with oligometastatic disease or disease that is very focal with only few sites, and palliative really when we're dealing with patients with diffuse metastatic disease. So when you get consultations for radiofrequency ablation, there's a couple of questions that you want to ask yourself, to ask the patient, and to ask the team. And that's first and foremost, what is the status of the disease? So what is the patient's prognosis? What is the lifespan that we're dealing with? That may very well alter your approach to treatment in that patient. What has been tried? So as Dr. Morris mentioned earlier, has this patient proven to have failed radiotherapy? Have they failed chemotherapy? Is this their only option to really get any kind of control? What is the patient wanting to achieve? And this is really important. So patient goals, I can't emphasize this enough. Are they really just wanting to be out of pain? Are they wanting to hike again? Are they wanting to just have more time with their family? So putting all these together, you have to decide, what are the goals? Is this going to be palliative or curative? And I'm going to take a little sidestep here because as I do consultations, there's a lot of question on what we're supposed to do in extra-spinal radiofrequency ablation. So I want to touch on this for just a second and talk about what lesions are appropriate. And in my experience, what I've found is that there are really three categories of extra-spinal tumors. And there's the painful ones. And what I found is that the painful lesions are the lesions that are abutting the sacroiliac joint. They tend to be very irritating, very painful. And on occasion, the lesions at the ischial tuberosity, because they're right at that hamstring tendon attachment, can be particularly painful for the patient. Then I have necessary lesions. So necessary lesions would include smaller lesions within the sacral ala that have the potential to go bad. They have the potential to start growing into the sacral canal, growing into the neural foramen, causing intractable nerve pain, which can be very difficult to treat. And then probably the most common request that we get in the extraspinal skeleton are these supraacetabular lesions. So supraacetabular lesions in the setting of a lytic lesion like RCC, lung, etc., can lead to catastrophic pathologic fracture. So we really want to be more aggressive in this area. And then lastly, I have the if painful lesions, and those are the ones in the iliac crest, maybe in the pubic ramus. Not always painful, but sometimes they can be irritating, and you go after them if they're really localizing to that area. So let's move on to some case examples and talk about our approach. So this was a 57-year-old female with history of colon cancer, and you can see on the images here, we really have oligometastatic disease. She only had a single thoracic vertebra that was involved, and she was having local pain there, both because of the involvement of tumor, and also you can appreciate that early pathologic fracture. So a couple of things to look at here. We do have some posterior extent of this tumor, and this is always very bothersome to me because there's very little time before this becomes really an operative case where they're going to have to do some kind of decompression. Patient will become symptomatic from that cord compression. So we want to be as aggressive as we can in this lesion while still being very cognizant of the fact that we have cord. We want to make sure that we've got nice CSF around there, that there's no real compression of that cord to begin with. And that being the case, we can cautiously and carefully try to get as much of that tumor margin as possible. So you may try and go for a curative effect here. And that's really what we did. We came in bipedicular, trying to get full coverage of the vertebral body with pullbacks there to try and get that posterior extent, and then did ablation into that pedicle to, again, try and get that posterior extent of the tumor. This was a patient with pathologic fractures, so we're going to put cement in there to prevent that delayed skeletal event of path fracture. This is a companion case, a little bit different, a little bit more uncomfortable, potentially. A 67-year-old male with metastatic RCC and focal back pain. You can see, again, similar story. We've got posterior extension of that tumor, starting to narrow the canal. This is very bothersome. We've also got the start of some pathologic fracture. We're in the thoracic spine, so we do have some neuroforaminal compromise that is arguably not as big of an issue as it is in the lumbar spine, but still can definitely be a cause of pain. So in this case as well, trying to get as much of that coverage of that tumor as possible to try to prevent any delayed skeletal event, cord compression, and further fracture. Another lesion, 57-year-old with endometrial cancer. This was oligometastatic disease. Similar story, posterior extension of tumor causing some early narrowing. You can also appreciate how much tumor involvement and enhancement we have at that costovertebral articulation. I found that this can be particularly uncomfortable, not only because there is some micromotion that happens at that joint, but also there's involvement of that intercostal nerve that can lead to a chest wall radiculopathy. So we were fairly aggressive with this tumor as well, trying to get full vertebral body coverage, and then pulling back to that costotransverse articulation and pedicle to try to decrease some of that posterior extent, filling with cement afterwards because of the pathologic fracture. This was the post-procedural imaging. This was the post-contrast. If you're able to get post-contrast imaging post-procedure, I would recommend it because that's really where you're going to see what you have accomplished. So you can see very nicely that ablation tract. There's some enhancement around the zone of ablation, which is normal to see in the post-procedural setting for several months afterwards. And then on the T2, you can see that there is some nice retraction of that extra-osseous intracanicular extent of that lesion. Moving into the extra-spinal skeleton, this was a 40-year-old male with RCC who had very painful pelvic metastases that were localizing to the posterior pelvis. So again, we're going to be looking for those lesions that are abutting the sacroiliac joint. And he had several, as you can see here. And there's really, this patient had very extensive disease. So we're going for more of a palliative treatment in this patient who just wanted to go on a couple more hikes with his family. So our approach here was to get as much tumor as we could abutting that sacroiliac joint to try and get him some pain relief, and then also getting the bone tumor interface along that larger lesion that was up at the more cranial aspect of the sacroiliac joint. And this patient had really remarkable pain relief, was able to kind of get up and move around for the last couple of months with his family. Moving on to this case, which I would consider a necessary lesion. This is a 62-year-old female lung cancer metastasis to the left acetabulum. You can see that tumor extending down to that subchondral bone plate in a very unfortunate area, that weight-bearing portion of the iliac bone in that supraacetabular region. This is a lesion that could potentially lead to catastrophic pathologic fracture. We have a very nice safety profile here, because we do have some important nerves, the sciatic nerve, obturator nerve, running in that area, but with that intact cortex and being diligent about our ablation zones, we really can get overlapping zones and try and get full curative local control. And that's what we did. We were very aggressive with the ablation, trying to get overlapping zones, as Dr. Morris mentioned earlier, and then filled with cement because of the lytic nature of the lesion and the weight-bearing bone in the pelvis. A companion case, a little bit different here, a 76-year-old male with lung adeno, and you can see we've got lesions in the supraacetabular region. This is that necessary portion of the pelvis where we really need to be aggressive, but you can see that the lesion is really growing down into the posterior acetabulum. As we get down to that posterior wall, things get a little bit more tricky. One is just the morphology of the bone is hard to get full tumor coverage. We've also got this very important structure right here, the sciatic nerve, that we want to try to avoid. So in this case, we were aggressive in the supraacetabular region. We were diligent in trying to get as much of that posterior wall as we could, but this is one that really we're going more palliative, delayed skeletal events, trying to prevent that, and then potentially sending the patient for concomitant radiation therapy to try and get any leftover tumor. This was one of those, if painful, lesions, 64-year-old male with bladder cancer and painful metastasis to the pubic ramus. They were very wary to give much radiation here because of the vicinity of the patient's neobladder. You can see here that there's some extent of tumor, soft tissue extent, that's abutting the bladder. So really trying to get full tumor coverage here is not really feasible. We want to protect that neobladder and just want to try to get this patient some pain relief. So the area we're going to go after is that bone tumor interface, and we just went straight down the barrel on both sides of the pubic symphysis and just ablated downwards, still being diligent to protect that bladder wall. And the patient had very good pain relief as well after this case. Really nice lesion here, 72-year-old male with prostate cancer and a painful met to the rib. This was his only site of disease, and he probably had some early path fracture starting. The safety profile here is pretty good. We're going to probably take out that intercostal nerve, but typically patients don't complain too much when they have such painful mets. The lung is in that area, so you do have to be cognizant of the lung, but for anybody who does lung ablation, you probably know the lung is pretty resilient when it comes to thermal ablation. It can cause some pleural irritation afterwards, but this is a very nice single probe local control case. And then lastly, I wanted to bring up a case that is probably the more typical case that you're going to get, especially early on. This was a 60-year-old male with urothelial carcinoma, very active, complaining of hip pain with the goal of just, again, being able to kind of get up, move around, and be with his family and be active for the time that he had left. And you can see here we just have extensive metastatic disease through the sacrum, through the pelvis, that supraacetabular region, all the way into the femora bilaterally. And you can see on the CT, this sacral lesion is very difficult to even attempt to get local control. If this patient was localizing here, you could get bone tumor interface along the sacroiliac joint, but trying to get full tumor coverage here is difficult for the size and location. So what we did was to go after those lesions that we thought were most likely contributing to his pain and the lesions that would most likely result in a delayed skeletal event. So we were aggressive around the acetabulum, really trying to prevent any significant growth around the acetabulum that might lead to fracture. And then we also went after this right iliac crest lesion because he was localizing very, very specifically to that area. Tried to get some cement in there to keep him upright. You can see he had that femoral pinning as well. And he was able to get up, move around, essentially pain-free after this for for a period of time, and was able to get out with his family as well. So in conclusion, curative versus palliative, things that we need to ask ourselves. What is the extent of the metastatic disease? Are we dealing with oligometastatic? Are we dealing with extensive bony mets? What is the size of the lesion? Is it feasible that we can actually get overlapping zones of ablation in this large lesion? Probably not. The smaller lesion's much easier to get local control. What is the consequence of growth? Are we in the spine or the sacrum where growth could potentially lead to intractable nerve pain or worse, paralysis? Are we dealing with the supraacetabular iliac crest where that pathologic fracture risk is very high? And then finally, what is our safety profile? Can we be aggressive in our treatment? What is the vicinity of those critical adjacent structures? And what is the risk of injury? So if you're dealing with, for example, like in this case, where you might take out one of the, suprascapular nerve, and cause weakness in the rotator cuff, that might be something that is less catastrophic than maybe taking out, let's say, an L5 where you're dealing with foot drop and difficulty ambulating. So all things that need to be considered, in addition to those questions that we mentioned: status of disease, what's been tried, what are the goals of you, the patient, and the team, and what is the patient wanting to achieve? So thank you very much for your attention. I'm going to hand it over to Dr. Levy, who's going to give us a rundown of some data.
Well, MK, that was a fantastic presentation. Thanks for that. Bring up a lot of questions, in terms of how you approach treatment of patients. One I'd have is you showed a couple of examples of a metastasis in the spine with posterior extension. Mm-hmm. And as you look at those, the question is, how aggressive should people be? One, should they take it on early in their experience? That'd be one question. And second, when you do these, how aggressive are you, and what are your goals of therapy for these patients that have posterior extension?
So that's an excellent question. Obviously, if you can get a hold of tumors before they have grown out posteriorly, that's ideal, because just as Dr. Morris was saying, getting those overlapping zones is critically important. That's harder to do once you get that posterior extension. I try to be aggressive in the posterior extent of the vertebral body, with the understanding that a lot of these patients will go to have concomitant radiotherapy afterwards. I think that that's important because you aren't able to get those really nice overlapping zones of ablation when you're dealing with the cord. There are a couple of things that I do look for. I assess the amount of canal stenosis. If there is some pretty severe canal stenosis and you have some contour flattening of the cord, that bothers me more, because then you don't have any buffer of CSF in between where your ablation is and the cord. That CSF is important, but you are able to overcome it, so you should not be cavalier. But it does allow you to push that ablation a little bit further to the margin. So I think it's a case-by-case example, or a case-by-case decision, but curious to see how others approach that.
So follow-on question to that, MK. So in those patients where you have posterior extension, you're trying to treat as aggressively as you can, how close are you trying to get to the cord, in terms of your ablation margin? The one you showed where you had a follow-up image, it looked like there was a fair margin still to the cord.
Mm-hmm. So with the radiofrequency ablation, the zones of ablation are a little bit more predictable. They're probably, in reality, going to be a little bit smaller than they would be larger in radiofrequency ablation. In other ablation modalities, that's not necessarily the case. So with RF, I feel fairly confident to bring that ablation zone up to a couple millimeters from where the cord is sitting, as long as there's not severe canal stenosis and there's some CSF still flowing around the cord. The other thing that we do when we're trying to be more aggressive is we will do neuromonitoring, but the problem with neuromonitoring is that you do have to know how to use it. So it's there's a learning curve in really interpreting subtle changes that you're seeing in the MEPs and the SSEPs.
So are you doing these with conscious sedation or general anesthesia?
So what we're doing largely is under general anesthesia, and a lot of that is just related to the duration of the case, more than necessarily the pain caused by the ablation itself. The benefit of doing these under conscious sedation is that you will get feedback from the patient often if you are getting close to nerves. So if you have the ability and you think that the case will be quick enough to do that under conscious sedation, then that's what we would prefer to do because of the increased safety.
Great. So last question. So when you're treating these patients, where you are, hoping for local control, and you do have these patients that have complex tumors, how often are you doing combination therapy of ablation plus radiation therapy?
That's an excellent question. So I'm a big fan of doing combined therapy if the patient is able to tolerate it, and they haven't exhausted that treatment as of yet. The reason being, as Dr. Morris mentioned, you don't always know where the edge of your tumor is. Even when you're getting PET or if you have MRI, it's, time has passed between that imaging and when you're doing the case. So it can be very difficult to know exactly where that margin is. So in patients where it's very critical to get local control, this is their only site of disease, they have potential risk of paralysis and cord compression, I will prefer that those patients go and get a combined therapy. If it's a very small lesion that I know I can get overlapping zones, I think it's less critical. Those patients will just treat and just watch them. But if there's any chance of any residual tumor, then I like to have them go for the added therapy.
Great, thank you.
I am Dr. Jason Levy. I'm an interventional radiologist at Northside Hospital in Atlanta, and I'm going to follow up Jay and MK's discussion of both palliative as well as more of a curative intent. And I'm going to go over the clinical evidence and the data that is out there currently. There is far more data in the palliative setting than there is in the curative setting, unfortunately. So we'll spend a little more time on the palliative setting. In this chart, what I brought out is 7 of the larger studies. All except for one were prospective studies, and some of them were multiple institutions. And what we can see from these, we'll get into a little more detail with each of these, but what we could see from these is in each and every study, there was a significant change in the mean pain score. In addition, a significant percentage of patients had clinically relevant reduced pain, which in most studies is 2 out of 10 points on the pain scale. And what you'll see here is anywhere from as low as 68 to 95%. And this was with decent follow-up. What I want you to focus on, though, is the column all the way over the right. So both Dr. Jesse and Dr. Morris were focusing on your goals in the palliative setting. So it's really pain relief, getting the patients back, maintaining their systemic protocol so that they don't have a mortality event, and preventing delayed skeletal events. So whether it's preventing a neurologic catastrophe with the cord or other nerves, or preventing fractures. One of the things that you'll see here is as time went on in the palliative setting, none of these cases, the bottom 5 studies, none of them had delayed skeletal events reported. And I think part of that is due to both time and what we've learned as an interventional community, as well as the fact that we started using cement in these cases to stabilize an axial weight-bearing bone rather than just ablating them. That's also important, though, the delayed skeletal events, because the other therapies that are out there, and we really need to be working together with those other therapies, but those other therapies that are out there, predominantly external beam radiation and or SBRT, do have an increased risk of fracture. And that has borne out in the literature in studies from Sloan Kettering and from Sunnybrook and from MD Anderson with increased risk of fracture after SBRT. So Matt, you were actually a co-author on this, and this was the original study that really brought radiofrequency ablation and percutaneous ablation for musculoskeletal metastases to the forefront. And this was on 43 patients. And this was the beginning of treatment. So most of these were very much chip shot lesions, keeping approximately 1 centimeter away from the cord or other major structures. But what we saw in this study with different locations was significant improvement in pain scores. The time frames that were visualized were at 4 weeks, 12 weeks, and 24 weeks. 95% of patients experienced a clinically relevant decrease in pain. There were a few adverse events, but again, most of these were related to the fact that this study was published in 2004. So something like a skin burn is related to a monopolar device that's not utilized anymore, really in almost any practice that I'm aware of. And a fracture of the acetabulum in these cases were not cemented, and that's clearly an axial weight loading bone. So I think that's why in many of the subsequent studies we didn't see these complications. I'm showing this study because, again, one of the things MK really showed well and Jay showed really well was we really need to decide what our goals are. And our goals in the palliative setting are going to be different than our goals in the curative setting. So this study was looking at who did the best, what can we correlate, what can we choose, and how can we treat these patients to get the best possible outcomes. And what we saw with this study was those with pathologic fractures did great, but equally, if not more important, you heard both of the prior speakers talking about the bone-tumor interface. So creating the ablation at the bone-tumor interface, exactly where those cytokines are released, will help reduce the cancer-related pain. And that was statistically significant, as long as we ablated the larger the ablation at that level. On the other hand, the larger the ablation overall necessarily did not improve pain results. And that makes sense. In a palliative setting, you don't necessarily need to chase all the tumor, but instead, the literature supports ablating at the bone tumor interface and trying to prevent a delayed skeletal event. So we've heard about being more aggressive if it's near the cord, and I completely agree with that. And then finally, one thing that we do see is the presence of a really hyperemic rim or an irregular rim may be related to increased pain afterwards. Just as a sidebar, that may be something that may entice a radiation oncologist to work, because that typically means that there's going to be increased perfusion in that area or increased oxygenation, and they work great in an oxygen-heavy environment. There has been some suggestion from some operators that vertebroplasty or cementoplasty, osteoplasty alone, or kyphoplasty alone may be the way to treat the palliative setting. Jay has already described that there are reports and case series out showing direct extension as well as extension through venous channels to adjacent vertebral bodies from doing that and displacing tumor cells when you're simply doing a kyphoplasty or osteoplasty. So this was a study comparing RFA with vertebroplasty and or osteoplasty versus vertebroplasty alone. And what we did see in this study was a reduction in the leaks that are the most important. So posterior and venous leaks. Clearly those could be critical leaks. And that also goes to support some of the prior reports that have suggested that RFA has a cavitary effect, allowing for a more even cement fill. Not a tremendous amount of data comparing radiofrequency ablation to radiofrequency ablation with radiation, but this is actually a study with radiation versus radiation plus RFA. This is the Osseous study in 2011. And a couple things about this study. I mean, obviously what you can see is a much improved overall response rate. So that includes a partial response as well as a complete response. And nearly half of the patients had a complete response. You may see that time to pain relief for RFA, which we'll see in other studies, including the one we just completed. That seems to be very delayed, but I would tell you when you look at this study, the time frame started when the patient got their initial treatment. So that time frame may have started, day one may have been when they're getting radiation rather than when they got radiofrequency ablation. It was not always a consistent order. Anyway, the bottom line of this slide is certainly radiofrequency ablation is not mutually exclusive and can and oftentimes should be combined with radiation, whether it's SBRT or external beam. I'm going to go over our study that is going to be published online in JVIR in November. This was a prospective multi-center study. We were accruing up to 250 patients. The primary endpoint was the worst pain at 3 months, and we were collecting pain, quality of life, opiate usage, safety measures. The inclusion criteria had to be in either the thoracic and or lumbar spine, or essentially the pelvis, the periacetabulum, iliac crest, and sacrum. So most of the cases that the two prior doctors showed. We did exclude pure osteoblastic tumors. However, patients with osteoblastic mixed tumors could be included, and your pain scores had to be greater than 4. Most patients' pain scores were well greater than that. The Karnofsky score had to be greater than 40. This is the patient population, and it's very typical for a osseous musculoskeletal metastasis ablation study. What I do want to point out, though, the only thing that is very different is a significant proportion of these patients were radiation naive at baseline. So 95% of them had never seen radiation before. So it's interesting because we would have thought that that would not be the case based on traditional pathways of treatment. But certainly it may argue for some of our results that were related to the ablation rather than any other therapy. 87% of these, this is actually on the first, I should point out that this data is on the first 100 patients, not on the full data set. So this is the first 100 patients. 87% of them had treatments in the thoracolumbar spine, while 13% in the pelvis and sacrum. The majority had a single, approximately 2/3 had a single site, 1/3 multiple sites. And as you could imagine, in the spine and or pelvis, the vast majority of patients did have cementoplasty, vertebroplasty, and or kyphoplasty after the procedure, so 96%. Here are our results, and I would point out that all of these were statistically significant at every time point, and most importantly, the rapid relief at 3 days was very exciting for us to see. So the initial time point at 3 days, we saw consistent drops in the worst pain in the last 24 hours. That was at 3 days, 1 week, 1 month, 3 months, and 6 months. That also the average pain and pain interference, so how much the pain was affecting patients' daily activities. Quality of life, measured by the European 5D index, also improved at each and every data time point, 3 days, 1 week, 1 month, 3 months, and 6 months. And similar to radiation before therapy, only 14% of patients underwent radiation therapy through 6 months after the treatment. Opioid use, which is challenging to follow, we did use opioid equivalent doses, and we did see a decrease of 46% of the patients reporting decreases at 3 months. From a safety perspective, again, as I said earlier, there were no delayed skeletal events. The adverse events were typically related to respiratory events. One thing to point out was this was a very sick population, and we were seeing them at the end of care. Despite the fact that they were radiation naive, there were 30 deaths. All of those deaths were classified by a clinical events committee and an interventional radiologist unrelated to the publication to be related to the patient's underlying malignancy and not the procedure itself. So, not a lot of time, but we will discuss oligometastatic disease with local control. There are papers out there discussing other modalities, but I only included papers that had at least a decent number of radiofrequency ablation patients. I will point to the fact that the data here is challenged. Almost all of these, actually all of these, were in single institution and retrospective studies. Many of them had mixed therapies reported, whether it was microwave and cryo or just cryo alone. And we had, some of the studies didn't report tumor sizes, which obviously is very important. Some of the challenges to the literature for oligometastatic disease is, like we said already, it's limited to multiple retrospective studies. And really there's terminology challenges. How do we call this? Is it local control, disease-free survival? Those challenges in these different reports making comparison very, very challenging. And then, as I said, most of them combine radiofrequency ablation, cryo, and microwave. Some of the consistent things that came across in most of the studies were reported size was similar to ablations, and really any organ size matters. So those tumors that were less than 2 centimeters had the best outcomes as far as local control. Patients who had metastases that were metachronous rather than synchronous tended to do better. Again, not unsurprising. And absence of cortical bone erosion or closely adjacent neurologic structures that may limit the comfort level of the proceduralist. And finally, lower number of metastases tended to correlate with improved prognostic factors. So I thank you for your time, and I hope this was helpful.
Dr. Levy, thanks for the fantastic presentation and summary of the literature in terms of what's been reported for ablation of patients that have, metastatic disease that requires palliation, and for oligometastatic disease. Question I'd have is you brought up the Distasso paper, and that's a treatment of ablation and radiation therapy, and show that the patients do better with combination therapy. Do you practice this way? What's your approach when you're confronted with a patient that requires palliation?
So yeah, I do practice that way, especially in some of the tumors that MK was talking about as well. I mean, similar approach. Our practices, we do ablation and, depends on our goal. I mean, for the most part, it's going to be ablation and cement first, followed by radiation. And the rationale for that is the more rapid pain improvement, and the fact that, the reality is they don't do as well with delayed skeletal events, namely fractures. And we do great if we're using cement in those cases. So we can prevent that. Finally, like I said earlier, I mean, we do provide an oxygen-rich hyperemic environment in the surrounding soft tissues and surrounding structures for them to potentially improve on their results. It is not a lot of patients that we won't send on for radiation. Anyone with epidural tumor, anyone with any kind of soft tissue component, which is really a lot of the patients in the palliative setting. I mean, whether it's delayed diagnosis or whatnot, it's just what you tend to see. So most of those patients go on to get it. I would argue that, we don't, in my practice, do a ton of oligometastatic disease, but in the cases where we are treating for oligometastatic disease, we do refer and do a combined approach with SBRT.
Great, thank you. So let's talk about cementoplasty a little bit. There's literature out there that would suggest you don't need to do ablation, that you could just use cement in treatment of some of these lesions. You reported on one paper that shows that maybe it helps in terms of extravasation. So how do you think about cement, particularly in the spine? What is the added benefit, of ablation in that setting?
So I think there's a couple of answers to that. So for starters, in 2014, Journal of Neurosurgery Spine, Cruz discussed, and there's been subsequent papers that I don't remember the exact reference, but Cruz discussed displacement through two mechanisms: one through direct extension through holes in the bone, and one through venous channels. So sort of going on to that subsequent paper. And what are you displacing? But he showed cases, and I've actually had one in my practice, where you created adjacent or nearby metastases. So I think the argument of getting that cavity with radiofrequency ablation is important. Second of all, I mean, there are people who say, well, the cement 60 to 100 degrees Celsius, it's going to create a radiofrequency ablation. And while that is true at the focus where the cement is, it's not like the cement propagates the way a radiofrequency ablation burn would. So it's really simply at the margin where it's touching the tumor. So I would argue that's not the case. And what are we? With cement, we're getting a great response for mechanical pain. We're getting a great response for motion. But are we really treating some of that biologic pain, some of the pain that's, that's related to the bone tumor interface? And I would argue that you're not. And I think that adding radiofrequency ablation, certainly from that perspective, makes it a much safer case. And then finally, in my experience, I mean, 9-10 years ago, I would be doing vertebroplasty and or kyphoplasty in these cases, and I'd be much less aggressive. And I'd turn patients away with blown out posterior walls. Now, with ablation, I feel much more comfortable because I do get that cavitary effect, and I feel like I can cement, kind of like what Jay was talking about, from more normal bone and bringing it back into that area and doing those cases.
So I just want to talk about, kind of how you might approach some of these patients. You referenced the chip shots, these sort of patient management. What do you consider to be a challenging versus a chip shot ablation?
All right. Well, I do apologize to Dr. Kallstrom, whose name was probably on almost all those papers. So I think a more challenging, in my experience, I find the sacrum to be sometimes more challenging than most of the spine. The anatomy is more variable. So I find that to be certainly more challenging. There are certain cases that I personally avoid with ablation, and I don't know if I'm answering your question. And some of this is actually the discussion with the folks at the Mayo Clinic. I really am very hesitant to ablate stuff in the femoral head and femoral neck. The cement doesn't work as well because there's more torsional force. I really am fairly exclusive in the pelvis and spine with radiofrequency ablation, with the exception of osteoidosteomas.
Well, that's fantastic. Thanks, Dr. Levy, for your fantastic presentation.
Thanks.
Dr. Morris, thanks for your great presentation and of examples of how you use ablation in the treatment of patients that have metastatic disease, particularly in the spine. Question I'd have is, you were one of the early pioneers developing a spine ablation as an option for patients. How have you gone about building your experience in a safe way?
I think it's a great question. Well, I had a lot of people ahead of me that have already built practices. People like Bill Charbonneau, people like yourself that I worked with that had a good infrastructure of bringing new technologies into radiology, people in interventional radiology like Jim Andrews and McCusick, who told me early on that you'd rather be a little bit safe than have a complication, catastrophic one, or even something morbid early on. So I think, I was taking ablation from other areas of the body, and although we had done a couple spine cases, you had done spine cases, I was taking it full on into the spine. So there were things that we didn't know. We had to learn how the ice behaved in a vertebral body. We had to learn how to use motor evoked potentials, sensory evoked potentials, how that free run EMG didn't work. And I think there was a long learning curve. And it's interesting that MK showed that case of that kind of what we would say, oh, that looks like a disaster. Because early on, that's the cases we got. They failed radiation, they failed chemotherapy, they already had their lung reconstructed, it's growing into the vertebral body, and there's no other options. And we really started with a lot of cases where there weren't any other options, and I think we tried to stay within the fairway. We work really closely with our surgeons, so we have a lot of backup around here at Mayo that maybe you don't have if you're out there by yourself. You know, that we work closely with radiation and neurosurgery and neuro-oncology and orthopedic spine just because I live in the neuroradiology world. And having that backup made me feel a little bit more confident that I could be a little bit more aggressive, but we really didn't want to injure the spine. So we took our time, and back then there weren't great radiofrequency probes, so we did a lot with cryoablation in the early years and trying to find out how aggressive we could be. And it turned out the motor evoked potentials were incredibly helpful in allowing us to grow ice closer and closer to the spinal cord and getting durable local control. And naturally, like any good practice, you start getting more referrals, because even if you just took all the patients who had radiation and either presented with a 40% bone loss in the lytic metastasis or a fracture, even if you just did radiofrequency ablation for those patients for palliative pain reasons, and in some cases helping with local control, like if they failed radiation elsewhere, that's a massive win for ablation, because those patients are undertreated, are in every community in the United States, and your radiation oncologist wants a treatment option for those patients because they're in pain. They might have fractured after radiation or are going to fracture, and they know that literature. So I think part of it is finding where the boundary was. Part of it was having good mentors. Part of it was learning the technology and what worked in what location, not being super aggressive up front, knowing the limitations of the technology and my own clinical equipoise. And then over time, developing techniques where we could get closer and closer and closer to the cord. And then there's just good old-fashioned customer service. You know, I come from basically the kitchen. I used to run gourmet restaurants for a living. Good old-fashioned customer service goes a long way when you're developing a practice. That means you're present. You're answering your pager. When people call you for help, you say, yes, I can help you, or I'll find out a way to help you if I can. And being available, accessible, part of the care team, I think is gone a long way to where we get now primary cases where oligometastatic prostate cancer, which could be radiated at, you know, straightforward fractionated radiation, they'll send to us now because they'll realize this patient's going to live 10 years, 15 years with biochemical recurrent metastatic prostate cancer. And we need to keep as many options in our quiver as we can. And having those teams of people that know you, that now respect you, that know that you're going to treat their patients well and try and improve their care and be aggressive, but not so aggressive that you're going to injure them. Nobody wants to take a case like MK showed and they come in with pain and they leave paralyzed. And there's 2 reports in the literature, and there's 3 more by personal communication I know where people have burned the cord or frozen the cord. It can happen, and people can be paralyzed. So I think when you sum all those things up together, being a local champion where you are, being available, knowing the technology, and expanding your range of where you feel comfortable doing cases just grows organically. And I'm sure Jason and MK have similar experiences. So it's a long answer, but I think that's the truthful answer.
Well, thanks, Jay. We're at the end of the hour. I want to first thank the panelists in this session, Dr. Jesse, Dr. Levy, Dr. Morris, for great presentations. I certainly learned a lot. I'd also like to thank the supporter of this session, Medtronic, who helped sponsor this with an educational grant. So thanks again.